the October 19th, 2020 COVID-19 clinical care rounds, EMS airway management during the pandemic. My name is Richard Hunt. I'm an emergency physician who serves as Senior Medical Advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer, real-time sharing of COVID-19 clinical challenges and successes. If I'm a clinician caring for COVID patients, the clinicians I want to learn from are those with the most experience. This is a voluntary public-private collaboration, thanks to the multiple professional organizations who have collaborated on these rounds. They are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges with other clinicians. Thanks to the National Emerging Special Pathogen Training and Education Center for their support with these rounds. NETEC has webinars that complement these Project ECHO COVID-19 clinical rounds. Thanks to Project ECHO, Dr. Bruce Struminger and his team for the peer-to-peer learning platform we use for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. Tomorrow, Tuesday, October 20th, will be critical rounds focused on rural perspectives of intensive care. This Thursday, October 22nd, will be emergency department rounds. Next week, we will change our usual format from the 3 a week to 1 combined special grand rounds that will combine home health, EMS, department, and critical care. And those rounds will be held next Thursday. Stay tuned for the announcement for those rounds. Hopefully the interdisciplinary nature of those rounds will be really helpful to those trying to sort through how to manage COVID patients in a very different way than maybe we've thought about before. I'm now going to turn this over to Dr. Bruce Struminger, who will go over some logistics.
Thank you, Rick, and a warm welcome to Michael and Chad, who will be presenting today. Really appreciate them joining us, and to our expert panelists and to the 200 plus participants. Thanks for taking your time and spending it learning with us. Just a few housekeeping logistic items. We really appreciate your questions and comments about the topic we'll be discussing today. Please put those in the Q&A feature along the bottom of the Zoom toolbar. If you have technical or logistic issues, please mention those in the chat and we'll be monitoring that as well. We'll also put a crowdsourcing question that Rick will share with us in a couple minutes. We'll put that in the chat, and please put your responses there. We really appreciate those. We are recording today's session, and your attendance is consent to be recorded, so thank you for that. The presentations for today should be available through the email announcement, through links in that announcement that went out today from Project ECHO. They will also be on our website within a couple of days, along with a link to the recording of today's session. For anyone who would like CME or continuing professional development credits, we offer those through the University of New Mexico, where Project ECHO is based. About 15 minutes before the end of the session, we'll put a link in the chat. There also should be a link in today's email announcement that went out. And we really appreciate the feedback you give us in the survey about today's session. And it really helps us guide future sessions and to improve these and try to meet your needs as best we can. So take advantage of the CPD opportunity. And even if you don't want the CME or CPD, go ahead and fill out the questionnaire so that we can hear from you. Just a reminder that these learning sessions are focused on improving patient care in health systems and supporting clinicians. So let's keep them apolitical and non-commercial. Thank you for that. And just a word about data use. We just want to ensure everyone we take data stewardship seriously, and what data is shared with Rick and HHS is de-identified. Most of it is all de-identified up front, but what isn't, we de-identify. And as Rick mentioned, NETEC is a partner in this initiative, and we just want to call attention to the fabulous webinar series that NETEC has been running since March or April, and they have a session coming up on Wednesday this week containing the spread of COVID-19 on inpatient psychiatric units. And they have an archive of all the webinars they've done over the last 6+ months. So we really recommend you join when you can and take advantage of the archive. Also, the AAMC is a partner in this initiative, and we want to remind everyone of the terrific clinical guidance repository that AAMC updates on a weekly basis. Again, a really valuable resource. So please take advantage of that. And with that, Rick, back to you for the crowdsourcing question.
Yeah, thanks, Bruce. This crowdsourcing question, I'll read it in a second, but there's some background on this that's probably important for you to know. Some of you have been on rounds last Thursday. Many of you may not have been. There was a really robust, thoughtful discussion during last week's rounds, emergency department rounds, which was focused on mental health support and fatigue and complacency, about the challenges with the words that have previously been used, and were they the words that are really helpful in making clinicians receptive to trying to figure out how to cope best during the pandemic. So in that spirit, the crowdsourcing question, which we will also ask in the emergency department rounds and critical care rounds, what word or words are better than mental health support and well-being to describe what clinicians need during the pandemic? What word or words are better than mental health support and well-being to describe what clinicians need during the pandemic? Thanks. You know, that might take you a while to think through a little bit, but really would appreciate people chiming in here. I think it's important. So with that, for our panelists, welcome. When we have our discussion, if you would please introduce yourself briefly, as we've done in the past, that would be really helpful. Thanks for all of you joining today. With that, I'd like to turn it over to our speakers. Welcome both Chad and Mike. Our first speaker today will be Chad Bowman, MSN RN, CCRN, CFRN, NRP, transport nurse and team coordinator for the Special Operations Response Team, SORT, at Johns Hopkins Lifeline. Over to you, Chad.
All right, good morning, everybody. Thank you, Rick, and to all the other panelists for the opportunity to speak here this morning. My name is Chad Bowman. I am a transport nurse and the team coordinator for the Special Operations Response Team at Johns Hopkins Lifeline. The SORT team is the team that would handle all of the high consequence pathogen transport for our biocontainment unit at Johns Hopkins. To share our response, some kind of background about our response to COVID-19 and kind of our mission profile. We do ground, rotor, wing, and then something that's unique to Hopkins is intra-hospital transport. So we're moving all of our ICU level patients in the hospital between ICU, procedure area, ED, any type of transport within the hospital. We're also responding to with our emergency response team. So this would be campus response, any type of visitor emergency or somebody that's not in a patient care area. And we supported transport for 10 COVID-19 biomode units, plus our adult ER, which had a significant number of areas that were in biomode during the height of the COVID-19 response. All of our ground and rotor transports are interfacility. It's rare that our medevac would be dispatched for a scene response in Maryland. We have the Maryland State Police. And as it relates to COVID, our helicopter was only used for time-sensitive patients or when there was a significant distance. We tried to do the majority of these transports by ground. So just looking at some data here from the last 6 months, this is broken down.
Rick, it sounds like we may have lost Chad.
Yeah, Chad, we're having a hard time. I think you froze up there. I'm thinking maybe go back out and come back in, Bruce. What do you think? And then if there's a challenge with that, then we'll go over to Mike for his. Yeah, there we go.
I think he just dropped off. So one option, Mike, if you're up for it, is we move on to your presentation, then come back to Chad. And
yeah,
absolutely. I guess in the meantime, somebody send him a text or something and just say, hey,
we'll do that.
You're not there anymore.
yeah, we miss you.
It's one of the perils of virtual rounds. Unfortunately, this has happened to me many times where, the internet drops out and there's nothing you can do, right? So
all been there. Thanks, Mike, for jumping in.
Should I go ahead and share my screen then?
Yeah, go ahead and share your screen. And then when he comes back, we'll just hey, Mike's on and we'll get back to you as soon as you finish. So we get through yours. Yeah, that'd be great.
Okay, perfect. So let me share my screen then.
Yep.
And we'll just keep our fingers crossed that we won't, that I won't drop off as well. All right, here we go. Let me minimize this. Can you see my screen okay? Looks like you can see me. So hopefully you can hear me okay. Again, my name is Michael Carr, and I am on faculty at Emory University Hospital in the Emory University School of Medicine. In that role, I'm also a medical director for DeKalb County Fire Rescue here in Atlanta, and associate medical director for Air Life Georgia, which is an air methods company. And similarly, probably more relevant to this clinical rounds, I act as a biosafety transport operations instructor for NETEC. And I've been doing that for a little over a year and a half. So just wanted, I'm sure Chad and I both had a lot of overlapping thoughts and pearls. I just wanted to hit on kind of, very high level, just 5 things that I would consider important to the COVID-19 airway interventions. So it is important to highlight some of the clinical features of COVID that have really informed decision making. And also just hitting on, the before, the pre-airway and adjuncts, stepping up to a non-invasive airway or non-invasive ventilation. And finally, once we make the decision to intubate somebody, what things are most important to consider, and then we can look a little bit at ventilator management. And I know, I believe Chad's talk was going to talk a lot about vent management in transport and vent switches and things like that. So maybe once he gets back on, he can kind of take over from there. So This is kind of based on my experience working as an emergency physician. Also, in chart review and in transports with air methods, a lot of these things will come up a lot. And what we're trying to do is make decisions on protocols and decisions with patient intervention that kind of revolve or informed by the clinical features of COVID-19. As you know, most of the morbidity mortality is going to come from this acute viral pneumonitis. A lot of inflammation that's going to reduce gas exchange. This evolves to acute respiratory distress syndrome. And as you know, there's a profound associated hypoxemic respiratory failure. And by now we've probably all seen that at some point. These patients there's a high level of intubation or mechanical ventilation in critically ill patients with COVID. And it's pretty atypical from standard ARDS or acute respiratory distress syndrome, where lung compliance is different. Patients with COVID-19 ARDS seem to maintain their lung compliance and the stretchiness of the lung tissue. So we see less complications of barotrauma. And also keep this in the back of your mind, because when we talk about intubation and vent management, this is something that's really important to pay attention to, because some of the classic interventions or treatment pathways associated with ARDS are not going to be as helpful in patients with COVID-19. And as I mentioned, a lot of decision making and how you treat a patient clinically is going to be informed by COVID-19 transmission, transmission-based precautions, and also guidelines. Public health guidelines are informed by a lot of the physiological or clinical features that we see with COVID-19. So some of the basics, just to touch on, in terms of pre-airway interventions or early oxygen therapy, would be considered our low flow interventions. By now, I'm sure you've seen a COVID patient who's received nasal cannula, non-rebreather, or I made the point to say high flow nasal cannula traditional, because this has actually come up a lot in previous clinical rounds internally in our institution, where we might refer to high flow nasal cannula, and some respiratory therapists or criticalists would be thinking high flow, high humidity nasal cannula, which is like an Airvo or some similar machine that is delivering 50 liters per minute, high humidity, positive pressure, high flow nasal cannula. Lower flows, you can get up to 10 liters and put somebody on a bubbler and have it's a different nasal cannula that's going to deliver a higher flow rate. But typically those patients are not going to be beyond 10 liters. So that, a traditional high flow is different than the high flow, high humidity, positive pressure. Guidelines right now, the only guidelines that I could really see in terms of targeting SpO2 is the World Health Organization's initial guidelines that have been replicated and referenced. And the initial target for acute respiratory failure is greater than 94%. Maintaining, as you know, oxygen does a lot of damage. We're producing a lot of free radicals. Free radicals are harmful to cardiac tissue, to lung tissue. So maintenance, actually 90 to 96 is really preferred in terms of oxygen maintenance. When we're thinking about nebulizing medications, there's some patients with comorbidities like asthma or COPD who might require nebulized medications. I'm sure by now you've seen somebody who might have a worse outcome because we held off on providing nebulized medications when they really needed it, because we didn't know their COVID status, right? So there are patients who are going to require nebulization of, let's say, a DuoNeb or albuterol ipratropium. And there are a lot of things to consider. And respiratory therapy and emergency department and EMS guidelines and protocols you should have a plan in place, such as limiting the number of people who are in the room exposed to the patient if they're receiving nebulized treatments. Wearing appropriate PPE like a PAPR or an N95 in addition, so your ACE, your airborne contact and eye shield precautions. And then also being in a negative pressure room with at least 6 air exchanges per hour. If a patient can use an MDI and you don't have to do nebulized medications, that's certainly preferred as a first line. So nebulizers really should only be used if absolutely necessary. So self-proning is something that's actually come up recently. There is kind of weak evidence pointing towards the use of self-proning in pre-intubation patients. So in patients who are just on nasal cannula or non-rebreather oxygen therapy, if it is feasible and if the patient is able to self-prone, that's actually anecdotally been shown to have some benefit. So while receiving oxygen, the patient can roll over onto their front. And as you can see from this graphic here, by doing that, and this is kind of the prone positioning argument, by doing that is we are opening up our posterior alveoli, and we're reducing a VQ mismatch, a ventilation perfusion mismatch, which is going to reduce alveolar shunting, and that is tremendously important. So the other thing that we're seeing is the heart is lower, and as gravity dependent, as blood flow is a lot easier to disperse when the heart is going to be closer to the ground. Also, other kind of practical and pragmatic things we're seeing is ability to manage secretions is really one of the benefits here. Some patients are able to suction themselves while they're laying on their front. Things like chest PT, those oscillators, airway suctioning, these are all things that are potentially going to aerosolize COVID-19 and should be avoided. Sputum induction is another one we're trying to avoid. Unless there's life-threatening emergency, bronchoscopy and positive pressure should really be avoided as long as possible. That being said, when COVID-19 patients tank, they really tank. Non-invasive ventilation is certainly an option. Early in the pandemic, you might recall, there was kind of a standard of care that was, or standard care that was being delivered or that was being discussed, which kind of reinforced that we should have early intubation on COVID patients and really avoid non-invasive ventilation like BiPAP and like high flow nasal cannula, high flow, high humidity nasal cannula. And, early on that seemed reasonable because we were trying to avoid aerosolizing COVID-19. It became pretty clear, though, that this should not be a hard, fast rule for many reasons. Number one is going to be ventilator resources. The more patients who are intubated, it require a higher level of resources, and we require a lot more equipment. And this is going to fluctuate based on peaks and troughs within COVID, within the pandemic. So really, when we're applying a positive pressure like BiPAP or high flow nasal cannula, we have to balance the risks and the benefits, taking into account the patient's benefit, but also exposure to healthcare workers and the best use of resources. So direct to intubation, I would say it should not be a hard, fast rule. And there are ways to work around starting somebody on non-invasive ventilation with minimizing dispersal into the room. Currently, as far as I can tell, on UpToDate and in some critical care blogs and let's say social media, there seems to be a preference for high flow, high humidity nasal cannula as a first line, but the data is really limited. And I think we will start to see more data coming out in future months about outcomes related to initiation of BiPAP versus high flow, high humidity. When we're using non-invasive ventilation, though, you really have to consider aerosolization of COVID-19. And there are many things that we can do to prevent this. Full face mask, for example, on your BiPAP patients or bi-level ventilation patients. By having a full face mask, you're reducing the dispersal of aerosolized particles around the room. Surgical masks over the nasal cannula or over your high flow, high humidity nasal cannula, that's something that you could consider to reduce the droplets dispersal. Having a patient in the negative pressure room where you have at least 6 air exchanges per hour, and then minimizing provider exposure. So if you don't have to be in the room, don't be in the room, right? And again, those should be included in airway protocols. People who are on BiPAP should, if possible, you should use a dual limb circuit. We prefer a dual limb circuitry because you can put a HEPA filter on the exhalation or on the exhaust limb. And that's one way. If you put a HEPA viral filter on that exhaust, you're really going to reduce dispersal into the air. Minimizing your positive airway devices for chronic conditions is something that we're seeing a lot in our hospital. Patients who might have obstructive sleep apnea but are not demonstrating hypoxemia or a severe airway obstruction, they might hold off on ordering your routine, CPAP at night, as an example. Now, when we get to the decision to intubate, this is all, the timing revolving around intubating somebody is variable, and decision making is also variable. This is a very challenging decision. Again, early on, we were saying intubate early, and that kind of evolved into, well, let's try some non-invasive approaches with protective measures in place that we mentioned, and then we can consider intubation if necessary. Most patients with ARDS are going to require intubation. So if you work in a hospital setting, you might see patients on the floor or in the step down unit or even the ICU who are peri-intubation or maybe have a deteriorating ARDS picture, getting ABGs sometimes every 1 to 2 hours. And this is just to monitor their status. Hopefully they have an arterial line where we can pull off some frequent blood draws and they don't have to get stuck so many times. But this is really what seems to be the current practice. Criteria for intubation is pretty variable though. Obviously rapid progression and deterioration is something we're looking for. When we get patients up to those high flow, high humidity, 50 liters per minute or more, FiO2 greater than 0.6, that's when we're starting to get worried. Evolving hypercapnia, increasing work of breathing, those are all clinical signs that we can see. Increasing tidal volumes, if you can see on a BiPAP machine, if somebody's really working and trying to pull more tidal volume, breaths might get more frequent. So tachypnea might ensue, and you get more shallow breaths as we're approaching intubation. That's because there's a lot of alveolar damage. And of course, worsening mental status. The goal for intubation, ideally, hopefully, would be trying to avoid hemodynamic instability and multi-organ failure. That is always a risk associated with intubation, though. As you know, intubation is going to be our highest risk procedure for droplet dispersion. Traditional laryngoscopy, where a patient's head is tilted back and you're sitting there looking with direct laryngoscopy as you're suctioning their airway and going to advance the tube, the stylet through the cords, those are extremely risky conditions. For that reason, having intubation kits and RSI checklists that are dedicated to aerosolization reduction is key. You might have seen some things in your hospital or in social media. What's the deal with this airway box? Airway boxes got really popular really fast because by nature they reduce droplet dispersal. It is unclear though how well they reduce the spread of aerosolized particles. Understanding that when we are dispersing aerosolized particles, they can remain suspended in the air for hours after they're dispersed. So as soon as that airway box is pulled off, that's something that could potentially happen. So really unclear efficacy, and just talking to people who have used them before, I've tried it maybe once or twice. The cons seem to outweigh the pros. It is, functionally and pragmatically very difficult to use. But if this is a protocol that has worked for you in your hospital and you have a way to minimize aerosolization dispersal, continue with what's working. And obviously a negative pressure isolation room should be used. And then the most qualified individual. I say one-shot doc. So actually that's because in residency, one of my first intubations with cold, sweaty palms and high stress environment, it was my first kind of crash intubation. Of course, the room is full. Well, there's one technician in the back corner watching me. Thank God everything went well. I got it in the first try. So that technician started calling me One-Shot Doc for the rest of my residency. I had a lot of nicknames in residency, but that was probably my favorite. That's a pretty good one to have. I can't guarantee that all the intubations that it followed were One-Shot Doc approaches, but that was a good nickname to have. And finally, considering things when you're working up to the endotracheal intubation, considering your bag valve mask, where the goal, as I mentioned, is to minimize your aerosols and droplets. If you have a BVM and you're bagging somebody, you want to minimize these droplets. Consider putting a HEPA or a hydrophobic filter using the 2-person technique, which I have another photo after this. But what if you don't have a HEPA filter? This has come up in conversation a lot. What if your agency or your hospital just hasn't purchased them, or let's say they're limited availability, you can't fill your supply? This is where I think you get creative and innovative as possible. For example, just putting a PEEP valve on the bag valve mask, which are pretty widely available, will reduce your droplet dispersal. Airborne particles, probably not so much, but it seems to me that it would reduce the number of droplets being passed into the environment. And consider dropping a supraglottic airway. After you've intubated somebody, or if you put a supraglottic airway down, let's say you don't have a HEPA filter. Some things that came up in discussion in the beginning of the pandemic, let's say for a cardiac arrest patient who was intubated, every time we're doing compressions, there are theoretically micro droplets being dispersed into the air. Consider after they're intubated, putting a sheet or a drape or something over the patient's head, which kind of sounds and looks morbid, but that might be one way to let's say shoot from the hip and try to get those droplets and micro droplets under control. And of course, using video laryngoscopy is going to increase your chance of first-time success if you're comfortable using video laryngoscopy. If you're not, then somebody hands you a GlideScope with a hyperangulated blade, and this is the first time you're using it, you might have a difficult time. So that's something to take into account as well. And here's a setup that Scott Weingart proposed on his blog, using to pre-oxygenate somebody or set somebody up for intubation, using a BiPAP mask here with a HEPA viral filter connected to a BVM with a PEEP valve. That's, you can continue stacking and get creative, but that's one possibility. So work with the supplies that you have. In terms of vent management, I just have one slide on this, and I know I'm probably taking too much time, but the low tidal volume ventilation is classically preferred for ARDS patients. So we're getting at less than 6 mils per kg of predicted body weight, or ideal body weight. And you might have seen the step ladder, the PEEP FiO2 step ladder there for lower PEEP and higher PEEP protocols. That was from the ARDSNet trials. So low tidal volume is, in my experience, still the preferred first line. When we see low tidal volume ventilation failures, we're starting to see some common practices that are being used in COVID-19 patients. Prone ventilation is one that's come up. As we know, with ARDS related to COVID-19, compared to other etiologies, COVID-19 ARDS, the lung compliance of these patients remains preserved. So with that, prone ventilation has been a lot more successful because of that compliance. So it's been a lot more successful in COVID-19 patients. So this is being considered first line in many hospitals for low tidal volume ventilation failure. Recruitment in high PEEP has actually been pretty well debated in the critical care realm. I found several letters to the editor and reviews highlighting that recruitment in high PEEP specifically could be detrimental to COVID-19 patients. It's controversial because with the increased compliance of the COVID lungs, you stand a greater chance of compressing the IVC, reducing venous return, and also increasing your pulmonary vascular resistance. So in that mindset, some things that would also be considered for LTVV failure is pulmonary vasodilators. Our paralytics, of course, are going to be in the algorithm. They should maintain there. And if you have ECMO available, when we get down and we are unable to oxygenate, ECMO is certainly an end goal, unfortunately, for many patients. So just to review, those are the 5 things that I kind of highlighted related to COVID airway management. But that's, that's really wanted to hit on. If you have any questions at all, I am available on social media, Twitter. If you're a tweeter and you have any questions, please feel free to send me at MCARMD. And of course, if you have an email and you have any questions, my email is available as well. So those are my references, and I'll stop sharing my screen here. And please let me know if you have any questions.
Yeah, thanks very much, Mike. That was a great presentation, great overview. I have a question. Wow, where'd he go? Chad, let's see if we get you back up there. And if you can go ahead and get back to your screen that you had left off on, that'd be great. And while he's getting that up, I have one question for you. There's some questions in the QA already, Mike, for you, but I have one. So based on your experience listening to, critical care, transport, paramedics, EMTs, and also, not critical care, but just EMS response, what is the most frequent thing that you hear from paramedics and EMTs in the field with their challenges with airway management?
That's a great question. I'd say pretty frequently. Well, there's obviously the first concern where difficulty determining COVID-19 status is something that frequently comes up. Because somebody's acute respiratory failure, undifferentiated, at the point of patient contact by EMS, it's terrifying knowing that this could be COVID. Clinically, we can look at a patient and say, oh, they're hypertensive, they're diaphoretic, they have crackles all the way up their lungs. Maybe this is a CHF exacerbation. How can we be sure that this is not COVID-19? I'd say that's a primary concern. And obviously, we've addressed this early on. Really, every patient now is being approached with standard, eye protection, surgical mask, and face shield precautions. But those patients where we're extra concerned that for COVID-19, most of our crews are wearing. This is within DeKalb County. They'd be encouraged to wear wear an N95 with their face shield. And also within Air Methods, that's kind of standard. When you're in a helicopter, that's going to be something we're concerned about in a closed cabin. So, that's probably the primary concern.
Yeah, thank you. Thanks very much for the presentation and that response. Let's get back to Chad. Chad, you're not the first one that's happened to by a long shot. So, and thanks for coming back, and we'll see if we can get you through here. So yell if you need help with the slides, but you're driving right now.
All right, sounds good. Thanks, Rick. Sorry about that, everybody.
Nope.
What I was starting to say was, looking at airway management for the COVID patient, I think you really, we're not changing a lot of traditional things that we're currently doing as far as intubation techniques, but we're adding a few things. So different PPE, the type of room the patient's in, maybe have them in a negative pressure room, and then some infection control and safety concerns during transport. So when we think about airway interventions for the COVID patient, and Mike did a really great job pointing some of this stuff out already, is we want to avoid emergent intubations. So we want to continuously be evaluating our patients to make sure that we avoid a situation where we're now forced into a situation where it's an emergency or an uncontrolled situation. We want to be able to take our time, make sure that we have the appropriate tools and resources in place before we intubate the COVID patient. In our hospital, we would utilize a dedicated airway team from anesthesia that would come for these patients. And then obviously in the emergency department, the ED physicians are handling those intubations. And if you're in a situation where you're in transport and you're the intubator, we want to make sure that we're optimizing the patient to make sure that our first attempt is the best attempt. So making sure that we properly position the patient, we're pre-oxygenating with a non-rebreather or a nasal cannula. We want to be avoiding mask ventilation if possible. And if we do have to do mask ventilation, making sure that we have that bacterial viral filter in place. When we think about non-invasive ventilation modes, high flow and BiPAP are the two most popular. For high flow patients, we just want to make sure that we're masking those patients for transport. That's our standard. We're putting a surgical mask over the patient to control those aerosols while we're in the back of the ambulance and also moving through the hallways in our hospital. And the medical consultation for flows greater than 40 liters or an FiO2 greater than 60 is not really a hard stop. We're not stopping there. That's more to get the crew to think about, all right, these patients are on high flow settings. Is this somebody who's gonna sustain during a ground transport, or are they going to need to be intubated before we leave here? Our ground program does not currently have an RSI program. The flight team is the only RSI credentialed folks. And then just thinking about those patients and is there going to be a need for intubation during transport, and we would want to preemptively do that before we move them to the ambulance. BiPAP, so making sure that we're considering the dual limb filter and having that bacterial viral filter on the expiratory limb. If possible, depending on your machine, making sure that you're using a non-vented mask. And then if it were a vented mask, we would just ask that the crew put a surgical mask over the patient. So this is our standard for our ventilator setups. You can see a bacterial viral filter there that we want to keep as close to the patient as possible. We do put double filters on our ventilator. Understand that that's not a standard for everybody, but that was recommended by our respiratory therapy department. And then we also add an inline suction device so that we're limiting the amount of times that we have to break the circuit. As you know, these patients can have pretty copious secretions. So having an inline suction device that prevents you from breaking that circuit is important. This is kind of a close-up of the tubing configuration. So we still have our end tidal attached there. We have our bacterial viral filter and then our inline suction device. And then there's a setup here without the inline suction. So when we think about, and our primary experience has been with ventilated patients. We move them to the hospital, through the hospital to procedure areas, to radiology, and then even our ground transports. We're dealing with patients that are already ventilated. So when we think about transitioning those patients from the ventilator to the transport ventilator, this is kind of the steps that we work through. We want to let the ventilator deliver a breath. We're clamping the ET tube, and then we are disconnecting the circuit, keeping the filter on the tube, and then we're clamping the ET tube, we're placing the ventilator in standby, and then we're disconnecting our circuit, keeping the filter on the tube if possible. We're switching the circuit, we're unclamping the ET tube, and then starting the ventilator again. And I have a video showing you that process here. So you can see ventilators delivering a breath, we're placing it in standby, clamping the tube, disconnecting the tube or the ventilator circuit, attaching the transport ventilator. We're starting and then unclamping that tube, minimizing the chance for dispersal of aerosols there during that tube change. When we think about PPE, we carry up what's called a P3 pack, a personal protection pack, and these were issued early on in COVID by the hospital, but our transport team has access to both PAPRs and elastomeric respirators. And then you can see the difference here. We're using a surgical gown for our ground transports, and then in hospital is the yellow isolation gowns originally, but they are on allocation right now. So we're using actually gowns that are made out of airbags. It's like wearing a shower curtain. But when we think about PPE, we require that our crew carry their PAPR with them in the ambulance when they go out, when they're leaving for a transport. And people tend to just carry the PAPR along for every transport, even if it's not dispatched as a PUI or COVID positive. And then of course, everybody's carrying their respirator or their N95. And we require a full face shield to protect the respirator or the N95 if you're not wearing a PAPR. We have, these are our isolation signs for the hospital. And I think that what makes these unique is that we're treating all patients with aerosol generating procedures with COVID, with airborne plus contact with eye protection as COVID PPE. But so any patient, regardless of their testing status, will have airborne plus contact with eye protection for any type of aerosol generating procedure. It doesn't matter. So when we think about aerosol generating procedures and transport, we want to make sure that we're masking all non-intubated patients. If they're intubated, they should have an inline HEPA filter. When we're in the hospital, we want to make sure that we're minimizing the door being opened and closed, and making sure that you have all your equipment before you go into the room. You want to limit personnel in the room, during a code or an emergent upgrade from the floor when we're called to transport patients. We can easily arrive and the room is so full that you can't even get to the patient. So just trying to limit the amount of people that you have in the room to reduce exposure. And then when you're in the back of the ambulance, we have our ventilation systems on non-recirculating nodes, and then we have our exhaust fan on. The cab is sealed from the front, and any time that we transport a COVID PUI or positive patient, we're allowing the ambulance to sit for 30 minutes with the doors open, running, before we're doing decon in the back of the ambulance. And then one additional thing that I think has really helped us stay safe in regards to all the patients that we've transported with COVID, but also for these more complex patients that are ventilated and maybe on nitric, or they have a lot going on, is we're using a transport safety officer. And we've actually added an additional provider for COVID positive and PUI patients for both ground, flight, and in the hospital. And they serve as the clean person. They're kind of your eyes on your PPE. They're clearing people out of the hallway or having them move to the side, so you're reducing potential exposure in the hallway. And it allows the providers to really focus on the patient rather than, maybe having to carry 5 bags down to the ambulance from the ICU after you picked up a vented ICU patient. So I think it really allows our providers to focus on the patient and not having to worry about making phone calls, getting people out of the way in the hallway and things like that. And I think that's all I have. Does anybody have any questions?
Yeah, Chad, thank you. Great visuals, a great presentation. So here's one quick question that I see pop up in the chat, and then I'm going to turn it over for a couple questions from our panelists. If you can take the slides back down so we can get the Hollywood squares, that'd be great. As you're doing that, here's the question. How are you sealing your front cab? Just closing the window or using plastic with tape?
We're using plastic with tape.
Okay,
Duct tape,
great.
yep.
Thanks. Yeah, there might be some other questions, and there are multiple questions that have been answered already, but some that have come up as well. So if you take a look at those, that'd be great. Dan, yes. And then one other question after Dan's, yes, or comment.
Hi, Chad. Dan Gerard. I'm the president-elect for the International EMS Chiefs Association. And my question for you is, you mentioned high-flow nasal cannula. And I might have missed that, but is that a transport-capable device, or are you just using higher flows with a normal nasal cannula?
Sorry, that wasn't very clear, but it is it's off of the ventilator. So it's a device, not running high flows on the nasal cannula. It's an actual device.
Thank you.
thanks. Any other questions or comments before we go to the polls? Carol, are you sure?
I'll just give a double thumbs up on the transport safety officer. I think that's a novel idea that can actually probably be transitioned to other environments.
Yeah, that one, the transport safety officer, but then the second, that one, and then, in air medical transport, spend lots of time thinking about that personally. But in addition, the one-shot doc thing, to me, certainly translates in terms of your EMS providers in the field or critical care transport. You want the one that's with the most experience, that's got the best shot doing any of the interventions for sure. I thought that was great. I'm going to switch over to the polls, given the timing. And if Echo could please put up the polls. There are some specific to airway management, and then there's one on PPE right there, and then one on mental health, fatigue, and complacency. And the reason why those are in there when we're doing an airway management is we're trying to track progress over time and to see where we all need to pay attention. So the PPE one, and there's been a lot of emails around PPE recently, and wanted to check on where this is today. And also for each of these questions, there's options like you don't know or you don't work in an EMS organization. So everybody has the opportunity to respond. We got 46% of you voted. And also, as Dr. Streminger noted, we don't use individual respondents in any way. It's aggregate. So you get to see these results just like we do. We'll give it just another 5 more seconds. 57% have voted. All right, Echo, why don't you go ahead and pop that up there? 59% of you voted. That's great. And it looks like N95 masks at 21%, the most frequent response, followed by, well, no, not short of any PPE, 31%, but then N95 masks and then gowns. Thank you very much. All right, next. Next few, I believe, are around airway management. Yeah. Our EMS organization has adapted our airway management protocols for suspected or diagnosed COVID-19 patients. And thanks for jumping on these quickly. It's really helpful. Also, I did note in the chat the PPE that fits issue. I obviously need to step up that game in terms of my polling responses there. All right, another 5 more seconds. Let's stop there. 62% have voted. It's great. 66% said yes. 9% said no. All right, thank you. Next. Our organization staff has had COVID-19 specific airway management training. All right, 62% have voted, just another 5 more seconds. All right, let's stop there. 65% voted. 47% said yes, 29% said no. Thank you. Looks like an opportunity there. Next. Our organization's equipment and supplies for COVID-19 specific airway management have been more than adequate, adequate, less than adequate, don't know, or don't work in an EMS organization. Dr. Kubas, see, really good point in the chat there on the questions. All right, let's stop there. 63% voted. More than adequate, 11%. Adequate, 48%. Less than adequate, 18%. All right. Next one. Next one, I believe. Let's see. Actually, I'm not going to guess. Yeah, I have learned about COVID-19 airway management for medical transport from, and there are a variety of options, so you can choose multiple options there for this one. All right, another 5 more seconds. And let's stop there. 63% have voted. And I'll let you take a few seconds to take a look at these results. And, you know, 63% of you voted. I just want to let you know when I share these results with the HHS Healthcare Resilience Work Group, 60% responses to any survey, kind of like you guys and gals knock it out of the park with this. And it's really helpful. Looks like webinars and other virtual platforms are winning the day on that one. All right, thank you. And then the next 3 are, I believe, are mental health fatigue and complacency. And this is for EMS agency practitioners or leaders since October 1st. So for each of these questions, this is since the beginning of the month. All right, let's stop there. 67% voted. Same 45%, worse 26%. Thank you. The next question, again, since October 1st. This is about fatigue for EMS agency practitioners and leaders. All right, 64% of you voted. Fatigue, less 1%, same 32%, more 43%. I'll let you look at that for a few seconds. All right, next. And this is the last question, I believe. This is same question, only complacency. Again, since October 1st. Another 5 seconds. All right, let's stop there. 64% voted. More, well, less 10%, same 31%, more 39%. And Bruce, help me out here. My thought, reflecting back on Thursday's emergency department rounds where we asked those same last 3 questions, I think they track pretty similarly. Yes? Yeah, very similar to, and for last week's emergency department questions, they were for emergency department staff or leaders, and they track very, very similarly to EMS. I'll do critical care again tomorrow, or I'm sorry, tomorrow. Yeah, if it's Tuesday, it must be critical care. All right. Well, thank you very much for the polling results. I'm going to turn this over to our panelists for last word comments prior to turning it over to Michael and Chad. So Dan, how about you? Yeah, I got to do the mute.
So I wanted to ask Michael and Chad, one of the things we've wrestled with is how to figure out kind of a balance in terms of airway care in the pre-hospital 911 environment. So which is better, to get the patient intubated outside the ambulance and then have the closed circuit, or to avoid getting in their face and using an SGA, or the concerns about using CPAP and you've just got an aerosol generator for the entire trip in the back of the ambulance. And I just wondered what your thoughts were. There's been a little bit of data in the literature, but not very much.
Yeah, let's start with Michael and then we'll go to Chad for that response. Yeah, Mike.
Sure, that's a great question, and full disclosure, in Georgia, ground paramedics cannot perform RSI, so we're not doing too many field intubations at this point. But from a pragmatic standpoint, I think it does depend on an individual agency's resources. For example, availability to apply a HEPA filter availability to have a closed circuit. And that, that seems obvious, but a lot of it also revolves around skill set and being able to demonstrate competency within that realm. So as you know, when you're intubating a COVID patient, you don't want to be hooking up a closed circuit for the first time. It needs to be something you're well practiced and well equipped to do, and it has to be consistent and do this, the same thing every time. So if you're able to establish that within your agency, I would say the data is not there, but my personal preference would be earlier airway intervention with a closed circuitry, as it might improve the patient outcome. But I think an SGA is a supraglottic airway is something that is reasonable, and that's what we're doing in most patients in Georgia.
Chad, anything to add to Mike's response?
No, I think the only thing that I would add would be that, in addition to the airway management piece, making sure that people have access to the appropriate level of PPE, if they're going to be in a situation where there is some type of aerosol generating procedure like bag mask ventilation, making sure that they have, an N95 or a elastomeric respirator on and a full face shield to protect them from aerosols.
Yeah, actually, that's an important point, and gives sort of like a new depth of meaning to allocation of scarce resources and the impact on that. So appreciate that. Dan, Gerard?
A great presentation by both Michael and Chad. Thank you very much. I would say that as we move into inclement weather and we're not going to be able to fly as many people as we would like, our biggest challenges are going to be in frontier and rural areas where we have extended transport times. And I would say to all the panelists on here, really start thinking about protocols and procedures, what you need to do moving forward. In order to protect your personnel, in order to provide the best care possible. Again, gentlemen, thank you. What an excellent presentation by both of you.
And actually, I hadn't thought about that. Okay, the cold weather is going to have huge implications. I mean, in many different ways, but the impact on airway management on EMS, I hadn't quite thought that one through. You absolutely right on, in my view. Alex.
Thanks, Rick. And also my thanks to Chad and Michael for joining the call today. My two thoughts are, one, PPE works if you're applying it properly and you know how to doff it without contaminating yourself. So that's key. And, all these interventions that we talked about, yeah, sure, some of them are aerosol producing, but through proper use of PPE and also remembering our environmental controls, meaning, keep your exhaust fans on in the back of the ambulance. Make sure your HVAC is functioning. You're getting, upwards of 30 air exchanges per hour back there. That's good for you too. This is how we keep our healthcare personnel safe.
Thanks, Alex. Rob?
Yeah, I just want to say thank you to the presenters. They were excellent presentations. I echo what everyone said here. It's so important that you guys showed us a way to safely perform these procedures and properly using the PPE and the filters and everything else, which is just really key to keeping everyone safe. But thank you for the presentations.
Thanks, Rob. Doug?
Just an observation, and again, same thing, two excellent presentations today. Observation, it sort of brings that all together, and the survey is that both of you had some little nuances and differences between the way your systems are handling these, but they're very checklisted and very much done in a way that everybody in the organization is doing things the same way. And I think that's one of the keys. Some of these, there's not a right or wrong answer, but it's really educating everybody in the organization to do things the way that is expected with the equipment that you have in the safest way possible. And I guess the one thing that bothered me on the poll was how the majority of people answered that they got their information from webinars rather than from the organization or the medical director and that sort of thing, which maybe it's the audience that's in the poll, but I would hope that most providers would say that they got it from the organization and there's a distinct way that they expect it to be done within their organization.
Hey, Doug, I picked up on that too. That, webinars are the number one way. I would hope that was different. I also know that based on demographics, the broad range of participants that we have, the resources across those participants also have a really wide range. And so how is it that we collectively support those that aren't nearly as resourced? And I think that behooves us all to think that through.
So Rick,
Thanks. Yes, David Gerstner, and then Carol. Yes.
the webinar doesn't preclude that it came from a local level.
That's
So
a good point. Good point.
we
Yes.
deliver a lot of
Good
stuff, including from our medical director via local webinars. So
Yeah. And yes, the polling responses and questions are less than perfect. We all are aware. All right, Carol.
I think this brings up another opportunity for us to think about different operational changes as we do head into cold weather. From an emergency management agency standpoint, we know that we have shifted and put up temporary hospitals, et cetera. It may be every state knows where their hot spots are, but if you have a hot spot you see that's developing, it may be up to a state EMA or local EMA to work with the critical care agencies and maybe set up a temporary station for ground transport where you know it may be needed more so people aren't waiting hours to get there. Just again, to be more dynamic and circular about it. And again, I compliment both the presenters. I love the transportation safety officer, although I hear TSO and I think Trans-Siberian Orchestra. So I might have to change that to a transportation safety team, unless everybody's singing, of course, but thank you.
Now I got songs hanging out in my head, Carol.
TSO,
There.
what's Christmas without the Trans-Siberian Orchestra?
I picked up in the chat a suggestion on EMS safety practices. I also picked it up in the chat a lot of back and forth about the PPE and the snowfall in Maine and how we're going to do the thermal protection and the COVID protection. Somebody's got to unlock that one if they haven't already, for sure. The last word to Chad and then Michael. Chad. And by the way, hey, thanks for plowing through the internet challenges and all that stuff. That it's not fun. I've been there. We've all been there. So just thank you for doing that. Okay. So yeah, your last word before we close.
Thanks, Rick. Thank you, everybody, for allowing me to present here today. And if I can ever be of any assistance, if you want more information about the TSO stuff, my email was not included in the slides, but you can, I would assume, get a hold of somebody at Project Echo. You can distribute that as needed. But thank you, everybody, and stay safe out there.
Yeah, thanks, Chad. Mike.
Similarly, thank you so much for having me. This was a great experience, and equally, I'm always available to questions. I provided my email in the slides, but please let me know if you have any questions. And also a big thanks to CDC, World Health Organization. I mean, people are working tirelessly on developing guidelines based on little evidence. So a lot of my talk was taken from expert opinion and what we'd consider weak levels of evidence, but there are people working on this full time. So thank you to everybody working so hard on that.
Yeah, thanks, Mike. And so I was going to try to find your Twitter thing. I guess Twitter handles One Shot Doc, but I'll work on it. So anyway, thanks to participants, Project Echo, to our panelists, always great insights for sure, and the panelists. Goodness gracious. The context around the mental health question and so forth, really struggling around these words, and words matter in terms of receptivity by clinicians for getting this figured out. So really appreciate that dialogue. The airway management, that potential topic came up through a participant, and then now we're looking at safety practices as potential. So it sounds like we're not done. I think this might, I don't know, Bruce, Amanda, and Amy, but I think this might have been our 80th rounds. I think, yeah, losing count for sure. And thanks to everyone who has made this an extraordinary peer-to-peer learning opportunity. Michael and Chad, thanks very much. My sense is you probably helped a lot of people out there, both the participants, but also some patients as well. With that, with gratefulness for everybody's participation, yes, take care of yourselves. Bye.